He has given guest lectures, invited guest lectures in both national and international ENT and Cochlear implant conferences. He has been guest faculty in many national ENT workshops. He has been a mentor for 45 ENT surgeons in India and 5 ENT surgeons abroad in cochlear implant surgery. His area of interest is in deafness surgery, endoscopic sinus surgery, microaligning surgery, and organizing conferences and workshops. He is a technical member of Karnataka government funded Rashtriya Bal Swasthya कार्यक्रम scheme for cochlear implantation, cochlear implant surgeon, and chairman of clinical trials indigenous cochlear implant project. He is the president Association of Otolaryngologists of India 2425. I request Dr. Jim Vaira Reddy to hand over a bouquet to our distinguished guest. Ladies and gentlemen, I take this Thank you once again. I welcome you all for this guest lecture.
Thank you, sir, for a wonderful introduction. I would like to now invite Dr. Shankar Medikeri, sir, to guide and enlighten us with his talk. The stage is yours.
Good afternoon, everybody. At the outset, I would like to thank Dr. Pushkara for Medical College, Superintendent, Dr. G.N. Vaira Reddy, Professor and Assistant of ENT, for inviting me for today's CME program and asking me to give overview on cochlear implantation. Because I would like to start off this cochlear implant program with the Medical College Hospital. We'd like to thank all the staff of Department of ENT and the postgraduates and all the other department staff and postgraduates who have assembled here to listen to me on this afternoon. So before I start my talk, I would like you to just see this 1-minute video and listen to this voice.
Hi, I am Tamnaro MP from Bangalore. I am here to tell you my journey from a baby who could not hear or talk anything to the most talkative student in the class. Yes, I am studying in class 8 in a normal school and I love talking a lot. As you can see, I was implanted with Cochlear when I was age 2. My mother took me to speech therapy classes regularly, which helped me to improve my speech and hearing skills. I never faced any challenges in understanding my teachers and friends in my school. I participate in all school activities, sports and cultural activities. Thanks to Cochlear for giving me the ability to hear and freedom to do whatever I like without facing any challenges.
Hi, I am Padmalata, mother of Tanmay. When we came to know that our 1-year-old baby could not hear, we were blank. We were not ready to accept that fact. But later on, we realized that there is no point in worrying about it than finding a solution. We were fortunate enough to find extremely good doctors, audiologists and therapists at right time. They persuaded us to go for cochlear implant immediately. Definitely, it changed not only Tanmay's life, even ours too. Thank you, Cochlear. I also take this opportunity to thank his doctor, audiologist and therapist for their time-to-time guidance and help. Thank you.
So as you heard about the child and the mother, so know what is the burden or what the parents feel when they come to know that their newborn child is not hearing and is deaf, and is left like that, is not going to speak also, is going to become a deaf too. So this cochlear implant surgery and followed by therapy is a really a life-changing treatment in the life of these children. Lakhs and lakhs of children who are born deaf, and if they are identified and managed early in life, they can be made to be a fruitful individual in the society, just like any other normal child. So before going to what is involved in cochlear implantation, I would just like you to see this small video.
To understand the groundbreaking innovations of nucleus freedom, let's look at how natural hearing and a cochlear implant system work. The ear consists of 3 sections: the outer ear, the middle ear, and the inner ear. All 3 sections work together to deliver sound to the brain. In normal hearing, the outer ear picks up sound which it sends in waves down the ear canal to the eardrum. These sound waves cause the eardrum to vibrate. The vibrations cause the tiny hair cells inside the cochlea to move. The hair cells absorb the movement and change it into electric impulses, which are sent to the hearing nerve fibers and to the brain. This becomes sound. A cochlear implant helps people with severe to profound sensory neural hearing loss or nerve deafness. A cochlear implant has 2 parts: an internal part called the cochlear implant and an external part called a speech processor. The speech processor uses 2 small microphones to pick up sounds. It turns those sounds into signals and sends them to a transmitter. The transmitter sends the signals through the skin to the internal implant. The internal implant converts the coded signals into electrical energy and sends them to the electrode array. This stimulates the nerve fibers in the cochlea, and the signals are recognized by the brain as sound.
So, over the next 45 minutes or so, I am going to give a brief overview of what this cochlear implantation is and what all it involves and what are the infrastructure and facilities required to have a good successful program under these headings: kickstarting a CI program, building a CIT, audiological evaluations, radiological evaluations, clinical evaluations, and counseling. Counseling is a very important part of this program. And cochlear implant surgery as well, and the post-cochlear implant rehabilitation, and how the outcomes will be of CI, a good successful CI. And of course, there are some problems like dropouts in non-users also in this program. One has to keep in mind. So when I say kickstarting a program, I know that every ENT surgeon would like to be a cochlear implant surgeon. So many of them, they have a dream to become a cochlear implant surgeon. So to be a good cochlear implant surgeon, one has to be an accomplished otologist. Good otologist with lots of hands-on training on temporal bone, of regular mid-ear surgeries, staphylectomies, and even cochlear implantation for that matter. And he needs to watch the live surgical workshops or demonstrations on cochlear implantation, and also assist in the beginning in cochlear implant surgery, how it is being done, the first-hand information, just standing next to the surgeon himself and assisting. And we should also have a good knowledge of not only the surgery, also the audiological evaluation procedures. What all audiological evaluation procedures are there to assess the candidacy for cochlear implantation, and also we should know about the hearing aid trial and hearing aid fitting, and how this post-fitting training habilitation is done. And we should also have a good thorough knowledge of studying and acquiring good knowledge of high resolution he himself should be able to read his scans and assess for himself and make sure that he is dealing with the right candidate with the normal cochlea and the normal cochlear nerve. So most important part in the CI program is the good cochlear implant team. Surgeon being the captain of the team, so he requires a lot of other assistants or other colleagues. He should have a good audiologist, a good speech language pathologist, and of course a very good radiologist who can report his scans properly and give you a proper report, and a pediatrician and a good anesthesiologist, especially those who are well versed in pediatric anesthesia. Because sometimes we are dealing with children as young as 1 year or maybe sometimes 9 months old children also. And the habilitation is a very important part of the CI program. I would like to say here the cochlear implant surgery itself is only about 15-20% of the whole program, and another 15-20% will be the candidacy evaluation by the audiologist and the radiologist. And the main remaining 50-60% goes to the habilitation. How much good habilitation is done post-implantation for the next year or year and a half, that is what is going to make difference. So not only the habilitation, it also involves the implanting, the motivated implanting, which is an adult also, or the parents of the children with hearing loss, or caregivers. Sometimes the parents may not be there, mother is not there, somebody else is looking out. And of course the social workers who need to help, or who can be of help for these families in need of any economic assistance. And apart from this, we need other clinical team, like a clinical psychologist to assess the IQ of this patient, and a developmental neurologist to look for any other developmental anomalies or delayed milestones, or a pediatric cardiologist because sometimes these children have an associated cardiac problems. Those also need to be studied. And of course an educational specialist, because these children or any needs to be brought back to the mainstream of education, and they have to be with other normal hearing children, and they have to be made and compete with these normal hearing children, and they should become normal individuals in the society. So what is the purpose of this team building is, so when you have a full team, your idea is, the captain's idea is to motivate these people and encourage their strengths and know about their weaknesses and address their weaknesses, so that everybody participates in the program in collaboration rather than trying to compete with each other. This team is important because, as it is said, any other team than for that matter, even the most innovative entrepreneurs cannot scale from an idea what they have conceptualized to an actualized success without the help of a team. That is why we need to have a good team to have a good outcome. So building a strong cochlear implant team is the main business plan for a successful cochlear implant program. So what is the role of this cochlear implant team is they should help in determining the candidacy for cochlear implantation, as you will know later how to identify, and they should help prospective recipient to make informed decision about cochlear implant surgery. Not that just somebody is forcing them on to go for cochlear implantation. The parents should make an informed decision, and this team will also help them to select, because there are different companies, different devices, which device to select. They help them in selecting, and they should provide medical care to carry out surgical implantation and also post-implantation device settings like mapping and monitoring or the further follow-up of the device in case of any problems in the exercise. And they should provide, the team should provide the post-implantation habilitation, as I mentioned earlier, because this is a very important crucial factor to have a good successful outcome. So what are the requirements? When somebody thinks of starting off a CI program, these are the things they should have in their setup. on these children with hearing loss and then start therapy, pre-implantation therapy with the hearing aids for at least for a minimum of 3 to 6 months and then assess whether those hearing aids are benefiting the children or not. A good operation theatre, preferably with the laminar flow, a good operating microscope, micromotor, different sizes of drill bits, speaker drill, and a facial nerve monitor. These are the requirements in the operation theatre. Of course, a good microsurgical ear instruments. A good anesthetist or anesthesia department is very crucial. As I mentioned earlier, if you are specially dealing with pediatric implants, so we need to have a good pediatric anesthetist who can take care of these children because this surgery is going to last for about 2.5 to 3 hours if you are doing one side. If you are doing a simultaneous bilateral implant, it will take maybe about 5 hours to 6 hours. That is including the intraoperative testing once the implant is placed and also an intraoperative radiology X-ray. And a good audiologist, as I mentioned earlier, for a candidacy evaluation and post-implant mapping of the children. Mapping is nothing but this will find out at different on the electrodes what is the comfortable level, minimum audible level, current level, and what is the maximum comfortable level. This has to be set at each electrode. That is called as the mapping. And this mapping is changed depending upon the therapy. Once in a week or 15 days initially, then maybe once in a month or once in 3 months later on. And a good rehabilitation team for giving both pre-implant therapy and assessing and also auditory vocal therapy post-implantation. So as mentioned earlier, I think these are all of my implant mentee surgeons. There are about 45 ENT surgeons in different parts of India. These are about some people and some of them, almost 1/3 of they themselves have become mentors now. They are going and mentoring other ENT surgeons. So to start off, once you have all these basic things, the most important aspect one should start off is the universal newborn screening program. I think any center, though in Western countries this is there at the government level, so every child born in a particular country, they are not sent without doing an OA screening. So but at least in India it is not possible. In Kerala they are trying hard, it is going on quite well. But in Andhra I don't know how far this is possible. But at least any center who wants to start off the cochlear implantation should start off with newborn screening. So here we have both otoacoustic emissions studies and the brainstem auditory response. Of course, if the otoacoustic emission fails, then we need to follow with the brainstem auditory response. So it is better to do both the things because there are some conditions where otoacoustic emissions may be present, like auditory nerve spectrum disorder and those with cochlear aperture abnormalities. That means there is no aperture in the cochlea, mesoderm of the cochlea, through which the cochlear nerve can enter from the intraglottic canal. So there will be no cochlear nerve stimulation in the cochlea. So in these two cases, we require a BERA. If we don't do the BERA, we will miss these two conditions. So, but how early one should do the newborn screening? So the newborn screening can be done in the first couple of days. Right? We can find out whether the child is passing the screening or it is in refer. If it says refer, so you can do it again before the end of 1 month and check again. So if it still says refer, better to send the child for BERA, brainstem auditory response audiometry. The main idea is because we have to identify early, there is something goal is set by the international consensus document, what is the 136 goal. That is, one should do the screening by 1 month of birth and it should be detected and confirmed within 3 months of birth that the child is definitely having a significant hearing loss, so that we should be able to intervene before the end of 6 months. We have children who have been diagnosed before 3 months, 4th month we have treated the child with a hearing aid, given therapy, pre-implantation therapy. By the end of 8th month, 9th month, we have advised implantation for those who are not getting children have undergone implantation, because this is the best way to do. Then, as you saw the first child, so after a couple of years, you will not know that this child was all deaf. So they will be as good as any other child with a normal hearing, born with a normal hearing. So every child born with significant hearing loss should be brought back into the mainstream education and should be made into a fulfilled individual in the society. That is the main idea of this reward screening. So these are the various audiological evaluations as I mentioned earlier. Behavioral observation audiometry, visual reinforcement audiometry, impedance, acoustic BERA, and other things to be added for the auditory study, state response, middle latency responses, late latency responses, and even some special tests, something like early speech perception test and the pattern perception test. The last four things may not be required in each and every individual case, but there are some instances when you need to do this to come to a conclusion and to make sure that you are dealing with a candidate for cochlear implant. So in children, the cochlear implant surgery, now the present guidelines is at 12 months of age or older, but there are some instances when they allow us to do within less than 10 months or 12 months also. And this should be a bilateral profound sensory hearing loss. That is how it started, this cochlear implantation. Of course, now we are advising even with a unilateral profound sensory hearing loss also. Then aided audiometry, when you do, I will show you a graph, when you do the aided audiometry after speech therapy. So if the thresholds are beyond the speech banana, what is speech banana and what is outside speech, I will show you in the next graph, then they are candidate for cochlear implantation. And if there is insufficient audition through the consistent hearing aid use to facilitate the development of functional speech and spoken language. Our main idea again is to listen, understand, and then speak. That is what we want these children to do. So as you see this, if there is a moderate degree of hearing loss like this is an audiometric chart. Yellow area, shaded area is the speech banana. But if you want to understand clearly all the speech, so your threshold should be within this. Whereas here it is just below the speech banana. So in a case like this, fitting a hearing aid and giving the child speech therapy, it will improve. All the thresholds should come within the speech banana. So hearing aid is good enough in this case. For example, in a ski slope like this, where the lower frequencies, the hearing is better than the high frequencies. So in this case, if you fit the child with a hearing aid, they will get good improvement in the lower frequencies up to 1000 words. Beyond that, the hearing improvement will not be sufficient enough. So why this high frequency is important, I will show you in the next slide. So if there is a profound hearing loss like this, then here the hearing aid is not going to benefit at all. But these children with the cochlear implant, they can come into the speech banana at all frequencies and they will be able to hear and understand speech and develop speech and language. So as you see, ear-specific audiogram. So as you see in this chart, so this is a speech banana. You can see all the vowels are there in the low frequencies, whereas the consonants, some of the consonants, they are there at very high frequencies, like 2000, 4000 and 8000. Like da, sa, fa, sha. So if your hearing is not in the speech banana at these frequencies, he is not going to listen or understand these sounds, these consonants. If he doesn't understand this, there will not be clarity in the speech, understanding. So that is why it is very important. So the unaided and aided audiograms are done. So if the aided audiogram is showing the frequencies outside the speech banana, even at 2000 and beyond that, they are the candidate for cochlear implantation. Now coming to the adults, you have 4 adults here. So you can see the first one is an 82-year-old lady with a progressive bilateral hearing loss, and she has used the hearing aid for almost 30 years. You see a sloping loss, typical of presbycusis, but even lower frequencies are much lower. There is another old man with a 75-year-old with a noise-induced hearing loss for 40 years with the bilateral hearing aids he has been using. Again, he has a typically like ski slope hearing loss. And another 53-year-old lady with a progressive hearing loss in 1 year and moderate hearing loss in the other year. Progressive severe loss. Whereas another 58-year-old man who had a sudden loss of hearing on one side and remained there not improved. One side is normal. Out of these four, whom you think is a candidate, because you have listened to now, whom you think is a candidate for cochlear implantation? Anybody's guess? In fact, all of them are candidates for cochlear implantation, because the first patient is the standard criteria where there are severe to profound degree of hearing loss. The second one, there is something called as a hybrid hearing, because the normal mild loss in low frequencies is left for an acoustic hearing. Only the profound high frequency loss is helped by the cochlear implant. This is called as an electroacoustic hearing, where there are shorter electrodes which are placed, cochlear implant electrodes, to stimulate only the high frequency sound, but we can still hear through the low frequency acoustic hearing to the lower frequencies. They can have an implant with an attached hearing aid also with that to help them with the lower frequency. And the third candidate is an asymmetrical hearing. One side of moderate loss of hearing, but other side there is a profound severe degree of hearing loss. He needs implant on the left side, and the right side may be managed with a hearing aid. And even single-sided deafness now has become as one of the criteria or candidate for cochlear implantation. So way back when it was started with cochlear implantation, it was unilaterally implanting the adult patients. It started with adults with a bilateral profound central hearing loss. They used to implant on one side. Later on, it became unilaterally implanting children. It was extended to children born with hearing loss from bilateral profound central hearing loss. And that too again implanting only on one side. Then they started implanting recipients not only hearing loss with other disabilities like autism, ALSDs, and other retinal problems, vision problems, those things, with multiple handicaps. Then they came later on the bilateral implant. They realized implanting both the ears, just like because God has given 2 years, so listening through both the ears is much better than listening through 1 ear. Then we started doing bilateral implants. So of late, what I mentioned recently is the implanting recipients with a more residual hearing. More residual hearing, as I mentioned, in the lower frequencies, you saw some graphs where there was only about 25-30 decibel loss, the residual hearing, but high frequency had gone to 90, 95, 100. So in those cases also there are special electrodes which will preserve the low frequency hearing and only help through the electrical hearing for the higher frequencies. And of now, we have ended up with the single-sided deafness. One side being normal, other side profound hearing loss, they started implanting. That was all the audiological part of it. And now coming to the radiology is also another very important evaluating procedure to identify whether the cochlea where you want to implant the electrode, is it fully developed, normal, or is there anomaly in the cochlea or a hypoplastic cochlea, or is it completely absent? That is very important to know. Not only that, even the cochlear nerve, just having a normal cochlea is not good enough. You should have a good nerve structurally, nerve connecting to the brain. So, or sometimes they could have an hypoplastic or a thin cochlear nerve. To evaluate all those things, radiology is very important. What I would like to stress here is the high resolution temporal bone scans. You have to take very thin sections, 0.625 mm cuts. If you don't take these thin sections, you will skip part of it, and when you evaluate, you don't get the complete picture of the cochlear anatomy. And for 1.5 or 3 decibel MR imaging system, referred for inner ear examination. So a thin section gradient ecosequence with heavily intubated, that is the best suited for evaluating fluid filled spaces of the membranous labyrinth, and also to identify the 8 gradient of vestibulocochlear nerve interfacial nerve. So CT and MRI both are very important. So in pre-implant evaluations, as I mentioned these things earlier, and post-implant, intraoperative and post-implant, the digital X-rays, we take is usually either the modified stainless steel or the trans orbital view. I will show you a couple of pictures of this. So this is how when we evaluate the temporal bone, we should get different cuts where you can see the cochlea from over onwards completely, basal turn, middle turn, appearing, middle turn, round window, everything, the ossicles, funnels, asteroid elevation, internal auditory canal, all these things we should be able to see in the scans. There is something called as a cochleogram, where you can see the vestibular cochleogram, assess the cochlea and also see the different semicircular canals very clearly and look for the ossicles and even the position of the facial nerve can also be identified. For the CT scan, we can also use to measure the length of the cochlea. There are different methods. Either you can measure by putting multiple dots around the cochlea and connecting them, or you can unfold this cochlea on the computer and then measure the length of the cochlea. This is important for selecting the size of the electrode or what length of the electrode you want to select. There are electrodes available from 16 mm. Department written an article, couple of us, in Indian Journal of Otolaryngology and Headache Surgery on morphometric analysis of temporal bone radiology for cochlear implant candidacy. This exactly describes what ought to be seen in a CT picture, MRI picture, and how it is to be reported, a common protocol which we follow in our expose this child to sound, speech, then only this will listen, understand and start speaking and develop into speech and language. That is why if we can detect in the first 3 months, 6 months, then we will have time to do a trial of hearing aid, a trial therapy. If not, by age of 1 year, you must implant if it is required. So 1 to 2 years is the best time. Up to 3 years you can step. But if it is not, but at least if you have fitted the child with a hearing aid, for whatever reason if it is not implanted, continue with the hearing aid and therapy, then even if you cross these 3 years and put within the next another couple of years, up to 5 years, is reasonably good period to have a switch over candidates. But beyond 5 years, the outcomes will be very variable. So the take-home message here is the hearing aid fitting and trial therapy should be done in all children with severe to profound degree hearing loss, at least for a period of 3 to 6 months before advising cochlear implantation. Counseling. Counseling is, as I mentioned earlier, is a very important part of this cochlear implant program. Best time to, or a good time to counsel is the moment you come to know that the child has got a severe degree of hearing loss. That is the right time to counsel. Why we should counsel and what should we counsel, we will see in the next slides. Because what is counseling? Ultimately, it is counseling nothing but it's a process of assisting and guiding these clients, here the parents of the child, by a trained person on a professional basis. The main idea is to resolve if they have any personal or social or psychological problems or difficulties in understanding their child's problem and what is the treatment, what way they should go ahead. So those things have to be sorted out by the counselor with the parents. So as I mentioned, you have to catch them early, and early identification and early intervention is the key to success in CI program. So apart from this, one should set a realistic expectation about the outcomes. When we are talking to these parents and listening, we should not tell them that they are going to get the moon. So it may not be possible in each and every case. So what result you saw in the beginning may not be possible for each and every case. It varies so many factors. Not only the candidate or the pathology of the problem, and there are various what implants were using, how the surgery has gone on, what application has been done, all those things matter. So, but our ultimate aim should be to develop listening and communication through the spoken language. So as you see, this is the electrode how it is going to sit in the inner ear, and it is going to stimulate the cochlear nerve as you saw in the first video, and sending the information to the brain. So sometimes these children develop in the first year, second year, meningitis, post-meningitic hearing loss. This is an otological emergency because these children are going to develop deafness because of the fibrosis which is happening in the cochlea and the basal meningitis. So this fibrosis can get converted into ossification later. That is why earlier to intervene much better. There are times where we are done in the first month, second month post meningitic implantation. But if there is any problem of money, then at least we can open up and put there is something called as cochlear stenting. We can put some dummy electrode into the cochlea and leave it and go on later on when they collect the money and then remove the dummy implant and put the actual electrode, so that you already have a pathway for putting the electrode. Why psychological evaluation? Because the cognitive skills of the child are very important. You are putting the implant, you are stimulating, but if the child's cognitive skills are not good enough, they are not going to develop those speech and language. And behavioral issues like attention deficit, hyperactivity disorders, or if the children have multiple handicaps, all these things are going to affect the outcome. That is why you need to counsel these parents. Of course, a robust rehabilitation program is very, very essential for good outcomes. And the parental involvement and caregivers' involvement is much more important. Because the child comes to the therapy center 1 hour in 2 or 3 days in a week, that is not good enough. And there actually the parents or the mother are trained what to do at home and how to train. Because rest of 23 hours in a day, the child will be with the mother. So how much motivated they are and how much time and energy we are going to spend on this child, that is what ultimately going to determine the outcomes. We should also counsel about the surgery, what surgery, because many people are scared because the child's skull will be opened, it may damage the brain, things like that. You have to explain them and you have to tell them post-implantation when the machine will be switched on, how this mapping is done, and how often they have to come for therapy, what they have to practice at home, and what are the precautions they have to take with the implant in place. Those things are very important. We at our center we give one questionnaire which is made for both pediatric as well as adult separately. And when the parent is to go for implantation, the child, so the parents are given this questionnaire. There are 36 questions in adults and 40 questions in parents, asking them what they expect out of this. So they have to fill up this questionnaire and come and sit with us, me and my audiologist and applicationist. We will go through that questionnaire and tell them this is possible, this is possible, this is not possible, this is not possible. This is mainly to curtail their expectations. You have to be realistic in giving their expectations. Don't just promise them something which is not possible. So, the counseling, main important thing is you have to provide them information about the implant and what the implant does to the candidate, and they should have an informed consent. Means they should know all about the implantation before they make decision for the implant. So it is both their thinking mind as well as the psychological field. Emotional or psychological counseling also is very, very important. If they have any concerns about the implant, about the foreign body being put there, whatever, skull being not open actually, but they might think whether there is any going to be brain damage, all those things, questions and their concerns have to be addressed when during the counseling time. So realistic expectation, what I mean to say is, in the beginning, patients when they start hearing through the implant, they might have some difficulty in hearing and understanding. But over a period, the sound will be little, quality will be little different, like a robotic or a mechanical sound. Whereas later on, they will be able to understand step by step. There are three factors which will help to improve this sound quality. That is mainly the brain gets adjusted to the new auditory input what is coming, and there is a fine tuning of the auditory signal over a period of time during the therapy sessions and the mapping sessions. And these patients tend to adapt and become familiar with the new input. In a child, the child will be listening to the first time when they do the implant and switch on. Whereas in adults, they have worked for so many years what is the acoustic hearing. But when they hear through the implant, that is different. That is why they also need training. And as I mentioned, the amount of time and effort invested in rehabilitation is very important. Support of family members, learning new language, of course, psychologists. So ultimately, what I mean to say, the realistic expectations have to be created in parents before you go ahead and do the surgery. So coming to the surgical technique as such, this is a very important, all AD surgeons should know carefully. This is nothing great surgery as such. One is to do a good cortical mastectomy and prostate hysterectomy. Approach the cochlear may be either cochleostomy or round window. And we always practice soft surgical technique, what I will show you. And always practice hearing preservation technique as much as possible. And one should know about the possible complications of implantation and how to handle them. So in soft surgical technique, what is done is that cortical standard mastectomy and wide open prostate hysterectomy and exposure of the entire round window membrane. And if you want to do cochleostomy, then cochleostomy is placed anterior inferior to the round window, and opening the endosteum should be done at the end with the help of a 0.2 mm plain tube. You can drill till you just expose the endosteum. boundaries of the facial recess, which I am showing now, and then the posterior canal wall has to be thinned down as much as possible to have a good access into the middle ear. There is no need to exaggerate all the air cells. So as you can see in this temporal bone, this is a triangular area. This facial recess is bounded medially by the facial nerve and laterally by the cochlear nerve. I hope you are listening to this. And then superiorly by the impus buttress. So this triangle, as you see, it is wide superiorly and it narrows down as it goes to the cordofacial angle. So you saucerize this whole area and then try to open the middle ear in the superior part, then you come down as is shown here. See here, the right side is open impus buttress. This is the triangular area of open facial recess to the middle ear. So this is the round window membrane. Why I am saying there are two things, scala tympani and scala vestibular. If you make your cochlear to be anterior inferior or inferior to the round window, you will enter the scala tympani. If you make it anterior, you will go to the scala vestibular, but our main idea is to put the electrode into the scala tympani. These are the structures to be seen: influostapedial joints, stapedius, promontory, old window, round window niche, and the hypotympanic cell. So this is again a diagrammatic representation. You will see the stapes, and then you will see the round window. So inferior cochleostomy going to the scala tympani, this another one, anterior going to the scala vestibular. In case if you need your second cochleostomy into the middle term, that is done. I will show one video anterior to the oval window. When this is done, especially in cases of obliterated cochlea. This I just stop and strike. When you do a round window insertion, there is some projection in the inferior part. Sometimes it might obstruct your view going to the scala tympani, in which case it has to be dripped. And I would always advise to use facial nerve monitors during the surgery, especially so if you are dealing with a cochlear anomaly, when the course of the facial nerve also could be abnormal and you may injure the nerve if you are not very careful and if you are not using the monitor. And now coming to this one 6-minute video, the book Cochlear Implant Surgery. This will show. I just want you to go through this. So this is a laziest incision which is put behind this kind of post-oral incision. This is the processor template. This is a receiver stimulator template that is marked, and usually an orbital line is drawn. The receiver stimulator is kept about 45 degrees to this orbital line. And then we inject the local infiltration, 2% xylitol is adrenaline. Then we take this post-oral incision and elevate the skin flap anteriorly and posteriorly at the superficial level, leaving the periosteum intact. Then we raise a superiorly based periosteal flap, U-shaped flap, as you can see here. It is widely based onto the temporalis muscle, so that at the end of the surgery, when we put this down, we will be covering the whole receiver stimulator without exposing any part of the implant. This is a implant pocket is created posterior superiorly, subperiosteally, and then we take a connective tissue for sealing the round window or the cochleostomy. Then you put your mastoid retractors and do a regular cortical mastoidectomy with the overhanging cortical margins. Then I am hitting the posterior canal wall here as much as possible, and then I started drilling the posterior tenotomy area. You can see I am saucerizing from the impus buttress down, thin, and then I opened it initially just below the impus buttress, then I enlarged it down. So here you could see the stapedius locus, stapedius tendon. Just from here I am actually drilling the upper lip of the round window. Here you can see the round window membrane very nicely. This is the stapedius muscle. And then we are preparing the bed for the implant posterior superior to the mastoid. Because in these young children, the cortical bone is thin, sometimes you will need to expose the dura to see that your template, this is the template, should sink in completely to the cortical, the outer cortical level. For that, what we do, we leave an eyelid bone in the center of the bed and expose the dura in the periphery so that when you push, the whole eyelid gets pushed in. So here with the sinus natural cavity. You have a pointer. Right. So here I have left a small ledge of bone so that my electrode array goes underneath that ledge so that it is held there. Now the implant has been put into the bed. Now you can see with a 23 number hypodermic needle I am puncturing the ground window membrane, the interior part horizontally. Once it is punctured, you can see the perineum coming out. Then with a small right angle pin I lift up the ground window membrane, and here I am using an implant with an introducer. This is an advanced wireless implant, and you will see some blue marker here. As I am pushing, there is a fillet which is pushing off the fillet, and once this blue marker comes to the cochlea or the round window, then I will draw the fillet. So that now it is completely inserted, and I am packing the round window in the connective tissue which I have taken. I am using a periosteal tissue here to have it thick sealed, so that in future any biliary infection should not go through the cochlea to the meninges and cause meningitis. So I will move this extra length of the electrode here. This is allowing for the further development of the skull. So this point will ungroove and will not pull out the electrode. Just watch the stapedius muscle. Can you see that contraction of the stapedius muscle? So that is, we are stimulating each and every electrode and checking the stapedius muscle. So contraction of the stapedius muscle means your information what is stimulating the cochlea now going to the brainstem, going to the facial nerve nucleus, and coming back to the facial nerve. Stimulating, that means your electrodes will be in the cochlea and nowhere else, and it is working fine. And we measure the impedances of all the electrodes. On the right hand side you see there are less than 5, and these are the thresholds for each electrode for getting a neural response around the 22 electrodes. This is noted out. This intraoperative measurement will help us during the mapping sessions. So this is another short clip to show how exactly that stapedius, when we are stimulating, this is also giving a sound. Actually nobody does this stapedius reflex, many people we do it. So with each stimulation you are seeing the stapedius muscle contracting. Can you see that? This is for the electrical stimulation. So we not only did this step 1, step ahead, you see even with the acoustic stimulation like a musical stimulation. Can you see the stapedius dancing to the music? So all these things will tell you that your implantation has been successful and it is working well. Because this is the moment you come out of the OT, the parents are going to ask, how did it happen, it is working, it is not working, whatever it is. Then we also take a post-op check X-ray. As you can see in a modified Stendos view, you can see the implant, magnet, here the ground electrode is coiled, and the active electrode are coming here, and you can see here it is inside the cochlea. Can you see this curve inside the cochlea? And here also you can see it better. This was the perimodiolar closer to the modulus, whereas this side it is in the lateral wall. You can see a bigger circle. So we can make out. Apart from this, we can take a glance survival view where you can see the electrode in the cochlea through the orbit. This is on the unilateral one side, whereas in this you can see a bilateral. Both the sides have been done simultaneously. 2 implants with 2 electrode arrays within each cochlea. And there are cases here you see a normal anatomy and normal insertion, complete insertion. This what you see here on the right hand side of the upper part is within the common cavity, not in the normal cochlea. Whereas here there is some tip folder, I don't know whether you can make out, and the tip has folded over. This is one of the complications. If you find this, you have to remove and then reinsert. Here over a period of time, the electrode array has migrated. Actually what you see, it has become like a C, which was complete circle, 360 degrees, become like a C. The proximal electrode array have been extruded. So this is how you see normally inside the cochlea. There are 12 electrode implants, the 16 electrode implants, there are 22 electrode implants, depending upon. You can count these electrodes when you see these X-rays. So these are various depths of insertions which can happen, which you will see in the post-op X-rays. So this video was of a common cavity which you saw the X-ray. You see here, there was no cochlea, no vestibule separating. This was only one common cavity. When there is a common cavity, you find it in the area of the lattice and circulaculum. You don't find it here in the promontory. The cochlea is absent. So in such cases, we make an electrical opening and put one electrode in the common cavity. The neuroepithelium is always situated in the outer part of the cavity. So your electrode arrays have to go and sit in the outer wall. So we put a loop of the electrode array and then push a connectivity in the center, which will hold the electrode array in the periphery. So that when you do the test, you can see here is the neural response which is done, except for the first and the last electrode being got this, because first electrode is outside, which was held in another forceps, last electrode also is outside. These other remaining electrodes are in the cavity, and this is how the picture you will see on an X-ray. This is another post-meningitic tuning loss, where we have to do two cochleostomies. As I mentioned earlier, this is one cortical mastorectomy, posterior tympanotomy, and the first cochleostomy is done here in the usual position. Here I am removing the incus bridge, and then I am taking out the incus, and anterior to the oval window, just below the processus cochleariformis. That is the area for second cochleostomy, where I am drilling the cochleostomy. So when you are drilling here, your bore should be more vertical. Don't face it anterior, because just in front of this area will be your carotid canal. So one has to be very, very, very careful. So once you do that, you get an electrode array, one implant with a double electrode array. So where each one, instead of having 22, we have got 11 electrodes. So one electrode is passed through the second cochleostomy. This can go either retrograde, it may go down into the first turn, or it may go up into the second turn. And then another array is placed to the basal third cochleostomy. So because you are the partial obliteration of the cochlea, you will not be able to put the whole electrode array from one cochleostomy or one ground window. So that is why, so this is the double electrode array. You can see one ground electrode, and there are one apical array and a basal array, each having 11 electrodes. So in each cochleostomy, even if you put 7 to 8 electrodes inside, totally about 15-16 electrodes, that will be, you will be able to manage this child with the frequency transposition and manage it with only 15-16 electrodes instead of 22 electrodes. This is one of the common complications which you see in cochlear implantation, that is a CSF pressure. So when there is an abnormal communication between the cochlea and internal auditory canal, or if there is a enlarged vestibular aqueduct, then you land up with this pressure. So when there is a pressure, no need to get panic. So you have to wait few time, wait for the pressure to reduce, ask your anesthetist to hyperventilate and reduce the intracranial pressure, then you will be able to put your electrode. Here I have a special electrode which has got a cork and this stopper at the end of the electrodes. That is what I am putting here. So as you can see, once you complete the insertion, this cork is going to stop or seal the cochleostomy itself. So on top of that, if you want, you can put an additional connecting tissue. So once you have completed, on the right side you can see two pictures. One, just open cochlea, and the second cochlea, the mastoid, which was not infected. Later on, at the second stage, we went ahead. Only the receiver stimulator was removed. You could see I had to repeat the cortical mastodectomy to enlarge the scissors fibers or obliterate it by bone growth. And during this stage, we should dissect out carefully with the fine scissors all the fibrous tissue surrounding the electrode. Don't pull out the electrode array till the end. You have to preserve this. See how I am doing dissecting out. And sometimes you may have to widen the posterior interotomy also. But be careful. Use a diamond burst and dissect with a sharp pick or a swivel knife, or even you can use scissors. So here I am decongesting with a gel foam. After that, we make the bed. If it has to be redone, I am redoing the bed for the implant, the tunnel. Then we will house the new implant in place and remove that electrode array only at the end when you are ready to insert. You can see this is a tunnel which I made. This is a ledger board under which the electrode array go into the mastoid and then come into the medial. In this case, we did the type of the implant. We did two tie holes on either side using proline, 10 proline here to anchor the implant. So here I drilled further with the medial surrounding the round window of the cochlear screen. Then I am putting a new implant into the bed, as you can see here, and tie the suture so that the receiver stimulator is not in place. Now you can see nicely with the left hand I am pulling out the earlier electrode, and with the right hand, the moment I take out this is the opening, I am inserting the newer electrode. Here the newer electrode is a straight electrode, whereas the earlier electrode was a tweak of electrode and a thicker electrode. So better to use either a similar electrode or you use a thinner electrode whenever you do a re-implantation. Okay, there are various different manufacturers. I don't go into the detail. Advanced Bionics, Cochlear, Medel, and Opticon. So only is the device how to select could be the surgeon's preference or the patient selection. Only thing is I want to make sure that it is an FDA approved implant and it is MRI compatible, because we never know these 1 or 2 year old children when they require MRI to be done later in life. And the cochlear anomalies are thin cochlear nerves who have special implants to be selected at that particular day. Of course, in a government funded program, it is by tender, they select whichever company wants the best ability to do it. But most important, another part is the after sales service. How these companies are giving, that is very important. Because these implants are going to stay with the life of the child for the whole life. They should get a good service, after sales service. And parents should always make an informed, consent, decision about selecting the implant. If they require any guidance, we as a professional should give. Again, there are lateral wall electrodes and perimodular, shorter electrodes and longer electrodes, hearing preservation electrodes. I don't want to, there are some special electrodes as we saw for a lecture. So I don't want to go too much details about this. This will go further. So these are the basic things how the electrode design has evolved. Initially it was a straight electrode. When they started, then it became a pre-curved electrode which is modular heavy. Then it became a slim straight. The straighter electrodes usually occupy the lateral wall of the cochlea, whereas the perimodular electrodes occupy the perimodular position, that is the medial wall. So this again now the latest one has come with a slim modular electrode. Slimmer, but it has the modular. We don't know what will be the next design. So in very young children also we have started doing implants now, less than 1 year old child. There is actually whenever this surgery is performed by an experienced surgeon, with a pediatric anesthesiologist, followed by a good pediatric audiologist and habilitationist. So this benefits of surgery, CX surgery, both auditory as well as speech language development, within 12 months of age when you do, they really outweigh any risks of doing this surgery in a pregnant individual. So this last part is the habilitation, which is very important. Usually these implants are switched off. That means the outer part is fitted 1 month after the surgery, and then they go for regular mapping, as I mentioned. they require at least about a year and a half. And later on, whenever they go for higher grades, they might need some assistance by the therapist during their school going age. Then the main idea, as I told you earlier, is the mainstream school placement of these children. This is a very beautiful video. I want you to watch this. The first time when it is switched on, this was done during our All India conference I demonstrated. So when the not this response. See, now when she stays, you look at the eyes of the child. Eyes of the child. See, the expression what is being is listening something. So this is the first time the child is listening to the sound. Okay, that is the switch off. And then these children, what is done in auditory verbal therapy? There are different aspects which are covered. First is the audition. There is a listening training. They start with 6 sounds like e, like that. So what's single sounds and then single 2-letter words, 3-letter words, then 2-word sentences, 3-word sentences like that. Then language, both receptive and expressive language like I told you, and speech, phonetics and phonologies, then their thinking skills. They use different names, and then there is pragmatics and play to address the social behavior. And each of the repetition, there are codes which are set with standardized assessments. Means by the end of 1 month, the child should do this. End of 3 months, the child should do this. 6 months, they should do. If they doesn't do, then you have to be alarmed. You should see where is something going wrong. To reassess or reprogram the child, point out whatever problems are there, that they are called the red flags, then we need to address those red flags. So this is both training and application. In one of the children with bilateral implants, this is 5 months after implant. This child was implanted at 14 months. Same child, after 1.5 years and 5 years. The post-meningeal hearing loss child with bilateral implant. Okay, the bilateral implantation benefits, these are the functional benefits that include sound localization, include speech understanding in noise, and we are always sure that the Medikeri is implanted, and there is a balanced sound output to the brain for both the ears is coming, and your both the auditory pathways are maintained and they are kept very active. I think this is tracking the progress I would like to not go to this is very complicated. I was telling about dropouts. Sometimes, especially in these government programs, we see a lot of dropouts of people becoming non-users. Why this? If there is no proper therapy centers available closer to the house, you implant a child living in a far-off village, and you want the child to come to back home for therapy or every time may not be possible. So the government needs to assess or goes by for these, especially when you are doing a cochlear implant program in the government schools. And servicing the processor and procurement of accessories. This also is very important. You have to make sure, because this requires some amount of money, because this also has to be told to the parents during the counseling. Because on an average, if the parent has to manage on his own, at least about 1,500 rupees per month they have to use. Not that every month they have to spend 1,500, at least 12 to 50,000 rupees in a year. So we usually ask them to keep something fixed deposit in the bank and use the interest out of that as and when it is required. Because this, unless the government also provides these accessories and servicing afterwards, because initially there is a contract for maybe 2 years, 3 years, or 5 years. But what happens down the line? So unless we look into those things, there are going to be dropouts. We were already seeing, I think even in old Andhra Pradesh, even Telangana also, which was started first program, Rajiv Allocation, there are a lot of dropouts and non-users. The parents are not capable, they are not capable of spending money, and if they are not willing to spend accessories, so that is also one of the reasons for dropouts. So non-provision of service contract by the government, which I mentioned earlier. But apart from this, there are some additional disabilities like autism, cerebral palsy, moderate mental retardation, attention deficit, hyperactivity disorders. So these things from the family side, which also contribute sometimes for the patient or the child getting dropped out of the CI program or becoming non-user. So coming to the end, so if you are interested in seeing these children into the mainstreaming and you want to have a good successful program, so what you need to have a good assessment, both audiologically as well as radiologically, and do a good hearing aid fitting and trial therapy, and then decide whether the child needs an implant. So if the child needs an implant, then the child will undergo surgery with intraoperative monitoring and making sure that the implant is working. Later on, followed by good mapping sessions and programming of the implant, frequent visits, follow-ups, and you optimize the implant usage by the parents or the patients or the children. So with, apart from this, a good rehabilitation program that will ultimately lead to the mainstreaming of these children and successful cochlear implantation program. So this is what I have given a brief overview of what cochlear implantation is. So thank you very much for your patience. If there are any questions, I am happy to answer.
Thank you, sir. It was indeed a very educative and informative presentation. We are truly blessed to have this wonderful session today. I request Dr. Subramanian MK. Our superintendent, Dr. Subramanian MK, to felicitate Shankar Medikeri. Thank you, sir, for giving us time for from your visual studio. I would like to thank the audience the head of the department staff and the postgraduates of PES for gracing this occasion and their patient listening. We would like to thank the management of PES, Dr. Rupa Suresh, Assistant Medical Director, Dr. Subramanian NK, Medical Superintendent, and Dr. Krishna Rao, Principal and Dean, for supporting us in holding this program. I would also like to take this opportunity to thank our head of the department, Dr. G. N. Bhaira Reddy sir, and Professor Dr. Ashok Murthy sir for their constant guidance, and my fellow colleagues. Special mention to Dr. Dinesh, Assistant Professor, Department of Dermatology, the Audiovisual Department, and my beloved postgraduates, without whom this program would not be a success. Thank you everyone for attending this CME. I hope this event will prove to be a stepping stone for our endeavor in starting the cochlear implantation program in our medical college.
I think we should clap for the Department of ENT. We did not thank the entire ENT team for I include a professor at head of the department who, by using his personal influences and friendship, who got alumni of my college, who is a pretty senior, nearly 15-20 years. He joined earlier than us in the medical college. So it was a pleasure talking to him in the afternoon. Here, we wholeheartedly thank from the organization, the guest speaker of the day, Professor Medikeri sir, for a couple of reasons. One, for agreeing for his stature to come all over and to a small village like Kuppam and addressing an enthusiastic crowd who has joined, who are looking for how best we can do the cochlear implantation in future. Secondly, he has also promised that, and he has completed the gap analysis, and therefore we are going to do cochlear implantation in our organization. No matter whatever difficulties we get, we will promise you that it may take a couple of months or some statutory requirements and preparations. It may take 6 months or so. And I think first time within 3 or 4 days after joining MS, as MS, we had a debate in the Department of ENT whether cochlear